Welcome to week 3. We are going to continue part 2 of the Pathophysiology. We spent time last week talking about the different risk factors. We will continue a little bit of looking at risk factors when we get near the end of the lecture. But today what I want to go over, and this week our focus is on treatment of cardiovascular disease. Understanding that when someone presents with known cardiovascular disease, we want to know not only their risk factors, medications they're on, but we really want to know what type of intervention and treatment was done. So that's the key topics we're going to be going over in this set of slides. So when we think about coronary revascularization, we want to understand what some of the major procedures are. So we talk about revascularization. It can be the word CABG, C-A-B-G, coronary artery bypass graft, which you know that as standard open heart surgery, or it can be something called PTCI, sometimes it's abbreviated PTCA, percutaneous transluminal coronary intervention, which is a mouthful. But this is done in the cath lab, and we'll go over the different types of things it can be. As example, angioplasty, atherectomy, laser treatments, intercoronary stents, all of these things that are usually done in a catheterization, coronary catheterization. So a revascularization can be a full open heart surgery, or it can be where the physician's gone in and done an intervention using a balloon or a stent, both of which are really very common. When we take a look at surgical treatments for cardiovascular disease, if we're going to be using the open heart surgery, the CABG, the most common way they make the bypass graft, right, the new arteries for the bypass, the old blockages, are usually going to be commonly the femoral or popliteal bypass graft. We'll talk a little bit more and I'll show you what that means, how to bypass. The other way is to go into the balloon, in with the balloon through a coronary catheterization. Right? The balloon is deflated in this photo, and then they get it right into the blockages, inflate the balloon, push that blockage to the side, and be able to do a type of coronary angioplasty. So I think it's important to know the history because it really hasn't been around for that long. 1960s is really when we started to really see a surge of surgeons being able to understand how to do the procedure, and then it just increased through the 70s and then really took off in the 80s. But anyways, it's the most frequently performed operation. I have the number 600,000. By all means, it's more than that, and this number is an estimate, but lots and lots and lots, right? So really, really commonly performed is open heart surgery. So surgical technique, many of you that go on to an internship in cardiac rehab, I encourage you to ask if you can go into the OR and watch. Many of the rehabs will help facilitate that, get that organized for you. But what happens is they're going to go through the sternum, right? Take a saw through that sternum, open up the rib cage. Once they open up the rib cage, they're going to close off the aorta, cross-clamp that aorta, so the heart can be rerouted into what they call a cardiopulmonary bypass machine. This is the standard way that it was first done. It's still done this way, but now there's newer ways of doing it as well. We'll talk about that. But most commonly, they close off that aorta, they reroute the blood into the coronary artery bypass. So now it's going to be able to continue providing blood throughout everywhere else in the body, but not have that heart that's moving in the surgeon's hand. Another way of doing it is called an off pump. The off pump is where the surgery is done on a beating heart, so they don't need to go through the cardiopulmonary bypass machine. Again, it's physician preference, a surgeon preference, it's what's going on in the patient, what they're capable of. These things aren't really what we're interested in. We're not going to learn how to do the surgery. We're looking at how do you help somebody post-operation, what's going to go on. But I think the more you understand what the body has been through, the more we are able to empathize when they're complaining of some odd stuff and say, okay, I understand what happened in surgery. So here's a photo. Most commonly it's going to be through the sternum. They also could do a lateral, depending on where in the heart the blockage is, would depend if they're going to go through the medial aspect. But most commonly it's going to be right through the sternum. And as you see right here, it's literally like a hand saw. That's done. They just saw right through. They cauterize it, and then they've got this apparatus I'll show you later that holds open the rib cage so you get a really nice view of the heart. Again, if you can observe surgery, I would encourage you to do that in real life, not just on YouTube. So when they're going to use a cardiopulmonary bypass machine, they're going to infuse with cold cardioplegic solution. It causes the heart to stop beating, cessation of contraction. It decreases metabolic demand. And the heart can survive for many hours like this. There are many people in the art, their job is solely to control and maintain what's going on with the cardiopulmonary bypass machine. The vessels, as I mentioned earlier, the vessels are going to be used to bypass those blockages are going to also be determined by the surgeon. It commonly are going to be vessels, can be a vein, which sounds strange. They can turn a vein into an artery. If they're going to use a vein, it's going to be the saphenous vein, and the saphenous vein runs from up in the top of your growing down to your knee, and then again from the knee all the way down to the ankle. It's a very long vein. They harvest the vein out of the leg, and now they can sew that saphenous vein into the heart and make a bypass, right? So it's a vein. The other very common vessels that are used are the left and right mammary arteries. So right on your chest wall, we've got the subclavian artery. The subclavian divides off into what we call the mammary arteries. You've got one on the left and the right. They can unhook one on either side or both, cut it off, and then reroute it over into the heart. So they can be the left or right mammary arteries, combination of both, saphenous and the mammary arteries. We know that once they have the new bypass in, it's not like it's going to give them another 60 years. It can accelerate atherosclerosis, again, can happen. And this is important to tell you because people feel great after open heart surgery. They're getting blood flow they haven't had in many, many years. But if they continue on their old lifestyle, their old risk factors and being sedentary and eating food that's not good for them, that pathology of sclerotic plaque and atherosclerotic tissue, right, the endothelial lining, can be damaged. So how long can they last? Some people for 5 years, some 10, 15, some they never need to have another one. All depends on what they're doing in their life. Their risk factors are changing, the diet they're following, the weight they're losing, smoking cessation, all of these things. So the bypass is going to literally make new arteries, make a new direction for the blood to go through, so the heart is getting adequate blood flow. This photo is showing you some of the different vessels that can be used to make a bypass. So most common is going to be down at the saphenous vein. Common to do, the whole vein, or just from the growing to the knee, or again from the knee to the ankle. They'll remove as much vein as they need. The others can be on the arms, the radial artery, again, the mammary arteries in the chest, but there's a variety of locations. It's important to ask because a lot of times as they're healing, if they had removal of the vein in the arm, or artery in the arm, or the vein in the leg, that too is going to be part of our rehab that we're going to talk about as you're going through the exercise program. Now this, I think, kind of makes it all make sense to you. So when you think about what is a bypass surgery, so they're getting access into the chest wall. The heart is sitting right there. You know that our coronaries lie superficial. On the inside, we have our chambers, the atrium and the ventricle. On the outside, we have those superficial coronary arteries. So if there's a blockage in the coronary arteries, the bypass needs to be in. So let's show you an example. So we have these blockages. You see these black blockages as where the blockage would be. So here is the aorta. So here is the aortic arch, and here is a circle, right? So this is kind of like a hole punch. And they sew one end, this would be the saphenous vein. So they sew one end into the aorta. And it's kind of like a tube or like a straw or like a wet noodle, like a piece of spaghetti kind of thing. So they sew one end of the saphenous vein onto the aorta. And then it looks like this one's going back to the circumflex, which is that artery wraps around to the side, lateral to the back. And then they're going to poke another hole with the other end, and they're going to sew the other distal end, called an anastomosis. So they have both ends of the vein now sewed, one at the aorta where all the good blood flow comes through. Now that blood is coming through the aortic arch, through that saphenous vein to go beyond where that blockage was. So this is what we call a bypass graft, right? So this is a bypass graft. Now this blood is going to come through nice and clean and deliver oxygenated blood to this area of the heart. The other two bypasses, so this picture happens to be a triple bypass. I see 3 bypasses on here. This is number 1. The other 2 are from the mammary artery on the chest wall. So this is the artery that is attached inside the chest wall. They unhooked one of the ends, and then they sew the other end, same way they anastomose, they sew on the other end of that artery that was attached to the chest wall. Now it's going to be attached to the actual heart itself. So the blood is going to go up here through the subclavian, as it always did, but now it's going to go down here through that artery to get to the area of the heart, and then here's the left mammary. So this is a triple bypass. This surgeon on this photo used 2 mammary arteries, and the third is a saphenous vein graft. Here is an example of some of the apparatuses that you would see in an OR room. Again, you and I are never using these, but they're important to kind of be able to show you visually what's gone on with the body. They're really, their ribs are opened up. They've got, they're able to hold that open. This little clamp here keeps the tissue nice and still, so the surgeon knows exactly where they're sewing on. All of these, very interesting things that they're able to do this incredible procedure on. If the bypass is done without using the heart-lung machine, there's some nice benefits. They're going to avoid transfusions, needing blood transfusions. It definitely reduces just overall hospital costs, blood clots, decreased risk of stroke. Really, we see a lot of benefits for using, not having to use the cardiopulmonary machine, but again, in the very beginning, that was how the history of the evolution of how bypass surgeries happened, and then now you're seeing more and more what we call a beating heart surgery. So a beating heart is when the surgeon is able to still go in there and sew anastomose, sew those new bypasses, whether it's the artery or the vein, into the heart on a beating heart. I'm not going to take time during my lectures right now, real time now, to show you the video links that I've included, but I'm going to bring your attention to YouTube. As you know, YouTube is a great source for finding some interesting information. Many, many years ago when I taught this, I would get a DVD player from the library and show you this, but you can hop onto YouTube and watch some surgeries. And again, I encourage you to do this because as a really good clinician, you want to understand what the patient's been through. Just like, physical therapy and athletic training are commonly in the OR with an orthopedic surgeon and watching what happens. Because when we're then on the flip side, helping the whole person heal, we can understand a lot more of what they're healing from. So I do really enjoy these surgeries. Some of them are a little graphic and can be tough to stomach, but you know how to pause and stop if need be. So anyways, mid-cab. Mid-cab is when they're able to go in through the side. So generally they're going to use a candidate for a mid-cab, meaning they don't have to go all the way through that sternum, would be somebody who has a blockage over on the left side, and they're going to usually use the left internal mammary artery to fix it. So they only need to get a small access into the heart to be able to go in there and do their little fancy stuff, which is bypass the blockage, attach the left internal mammary artery. If you're not cracking open the whole sternum and doing the full operation, obviously the risk, the complications, the cost, the turning around back to work is going to be a lot quicker. Here's another example, another YouTube video. Again, this is what we call an off pump. This is where you can actually, it's very incredible. The heart is contracting the surgeon's hand as he's sewing on the bypass. Definitely worth watching. I don't know if you know how to sew a button or a basic even putting a thread through a needle, but sewing is really tricky, and surgeons are just incredibly skilled eye-hand coordination to not only be able to sew, but also sew on something moving, which would be the heart that's beating. So just with that, it's worth watching, and there's many more than just the 2 that I just talked about. So open heart surgery is, we've got a big sternum that's been cracked open. When they sew the person back up, they look like twist ties in an X-ray. They take a little wire, and they kind of like your garbage twist tie, and they twist tie back that sternum. The sternum is bone. It's going to heal over time. It takes time. But during healing, they'll have lost a lot of musculoskeletal strength, so we're going to want to address that in rehab. You also have to think about those that have removed of the artery in their arm or the big vein in the leg. That too takes time to heal, because once they cut that bypass and solder off where the vessel once was, the body's got to grow new. It's going to grow, especially in the leg. New veins are going to grow, and they're going to feel those growing. So when you think about the treatment, I want you to think it's not just about fixing the blockages, but it's everything else that's got to heal with it. So open heart surgery is fascinating, very, very fascinating. I encourage you to get onto YouTube and watch a few videos just so you can appreciate what someone's gone through. The next couple of slides I want to go over is another type of intervention, right? So PTCI, PTCA. a variety of different ways we can abbreviate it. Balloon angioplasty came after open heart surgery. So open heart surgery was in the 60s. I is super itchy, I apologize. Open heart surgery was early 60s, 70s, and then mid 70s is when they started doing angioplasty, which is balloon. So in the cath lab, the coronary catheterization lab, they would take a guide wire and get it up into the aorta. How they get access to that guide wire into our body, they can go in through the artery, through our arm. They can go in through the growing, from where your inguinal creases, and go up that way, up into the aortic arch. Everything is connected inside. So they just have to get their access point, right? They do a little incision, guide that guide wire all the way up, and now it's in the aortic arch. Once the guide wire is in the aortic arch, there's lots of great equipment that's able to get them to watch, to see, right? That's what the coronary angiogram is going to see. There's x-rays in there. Anyways, they're going to guide that wire all the way into where the blockage is. So they're going to put that guide wire right into the blockage, the fat, the plaque, the atherosclerosis. Once it's in there, the person usually does not feel good. They're awake, conscious, lying on the table, right? So they usually try to keep them awake and conscious because they want to talk with them. If someone gets too anxious and too upset, they can sedate, but they really want them to be talking. So anyways, as they put that guide wire into the blockage, a lot of times people will begin getting ischemic and not feeling good. As they inflate that balloon, as you see in this photo, they really aren't feeling good because now they're getting no blood flow, but it's for a brief, short time span. They're going to inflate that pressure, that balloon pushes the plaque all the way out to the edges, and then back in the day they would deflate the balloon, send the person home, and hope that that plaque just stayed on the sides. Now there's been incredible inventions of stents, which I'll show you in another photo, that's going to help keep that open. Now if someone has percutaneous transluminal coronary intervention and angioplasty, right, their length of stay is not going to be nearly as long in the hospital as it would be if they had open heart surgery. So here's a balloon angioplasty, right, guide it right in through the aorta, it goes right into wherever that blockage is that they've been able to identify in the angiogram, inflate the balloon, push that blockage to the side. So, angioplasty, right, that's what we're talking about. Local anesthetic, access either through the femoral or the brachial artery, the guide wire steered all the way in, so it's under x-ray, right, that's what I mentioned, they can see what they're doing, the cardiologist can see it. They're going to find the stenosis, find the blockage, then they're going to inflate the balloon beyond the diameter to really push that blockage to the side, hold it there for a short stint of time, and then deflate that balloon and bring it back. Now, there are different tools they can use, right? The balloon angioplasty, it's pretty decent. Sometimes they need different types of tools in there, but the death rate is pretty low, 1 to 4%. If something happens, usually we're going to revive them right away. Death rate as you experience after CABG is around 5%. So, the risk for both is very, very similar. The most common problem that happens, complications, what they call abrupt closure, and it's when the intimal layer dissects, right? Kind of a thrombus is formed, and it just ends up kind of abruptly causing vasoconstriction. So that's what we call the dissection of the artery. That can oftentimes, that if there's going to be a complication, it would be that. So obviously this is a foreign substance being put in the body, right? The balloon and then the stent. So preventative pharmacology is going to say, well, we need to thin the blood, and that's going to be aspirin, heparin, platelet inhibitors. Really try to get that blood as thin as it can so that the body is beginning to sense that, hey, there's something foreign, we need to send cells there. We're not going to have as much of a problem with healing. So complications after can be restenosis. So restenosis meaning, it was a clot forms, plaque goes back in there. Restenosis rate can vary. It says most common 3 to 6 months. You can see it even earlier in that. One of the biggest things that we see is going to be angina symptoms. So angina usually is progressing stenosis that's happening. So in a rehab setting, that's why we really want to watch their subjective complaints, because if they're beginning to have shortness of breath, a little angina, it could be signs of restenosis happening inside there again that they want to take a look at. Many years ago, I used to be allowed to bring exercise physiology students into the cath lab, and we would be able to stand and watch. And it was just always incredible to go in small groups, but obviously it's a long time ago. And I say that because we would stand behind the nurse in the cath lab and look at these photos. And in the beginning, you're like, I don't even know what I'm looking at. So this is what we call an angiogram. So the angiogram is showing you the differences between the blockage, right? So here on A, you see it's really difficult to understand what you're looking at. You're looking at the heart, and you're looking at the coronaries of the heart. But here on A, it says there's about a 95% stenosis of this is a circumflex artery. And then over here, this is the same person, same artery. They inflated the balloon, pushed the plaque to the side, and they put a stent in there. What do you notice the difference? This is a foggy looking gray artery. You're not seeing a really nice strong line. And over here you see a very nice strong line. What is the difference? Blood flow. So in the second photo, this balloon, angioplasty balloon, in a heart catheterization has been deployed, and now that person is getting plenty of blood flow, right? We call that revascularized blood flow. Stents are an incredible thing, right? They're still continuing on perfecting how a stent works. But a stent is like a little fence. It's I have my boxes from packing at my office or in the garage, but in one of my boxes, I actually have a little stent. I should have brought it and showed it to you on my on the video here. But a stent is about as big as a spring and a ballpoint pen. So if you've all taken apart a pen, you see that little bouncy spring that's in there. It's kind of the size of most stents. They can vary. But a stent is going to be deployed after the balloon has been inflated, and that stent is going to hold the plaque on the side of the lumen, and that stent is going to be beneficial at over time, hoping that we have more longevity out of the stent. Various metals, different strength, there's different ways that they've improved stents with coating it with different types of medicines or chemicals, so they're releasing more blood thinners, and all this fancy kind of biomedical inventions have happened for the longevity of a stent to be really enhanced. So in the beginning, there were a lot of setbacks with stents. They've perfected them, but some of the disadvantages is just simply the risk for blood clots, and that still happens today. Blood clots, because again, it's a foreign subject, and those cells are going to get mad and go and help say, hey, there's something in here, we better swim over and, do our thing. But with the right level of anticoagulants, platelets, blood thinners, Coumadin, heparin, all of these things, they really stents can really do a really great job at keeping the blockage from inhibiting blood flow going through the coronary. Here's a photo of the stent. So I showed you how first there's a balloon. The balloon first gets inflated, and then after the balloon is inflated, the stent is then deployed. Again, I have videos. This video is different than the other YouTube videos. This video goes directly to a website that talks all about the invention, the evolution, different types of angioplasty. Again, if we were in class, I would pause and make us all watch these together, but I think after I'm done with the Zoom, you can do this on your own. One interesting thing is how and who discovered that you could put a guide wire into your body and put it into a beating heart. So that story is on this website, and it happened to be a German physician, and the German physician he was a student, he was a resident in Germany back in the 70s, and he had this brilliant idea that he wanted to try this. And he spoke to his higher-up attending physician, and as soon as he shared his vision of how he believed he could get access to the heart, he was immediately fired. Right? Again, this was Germany in the 70s, and he was, sharing an idea that was not as regimented as what they were following. Anyways, for just having this idea, he was pretty much shipped out the door and ended up at a new hospital. Moves to another hospital, he still is just burning with this feeling and doing research and knowing that there's a way that we can get access into the body to do this. So the website does a better story of it, but ended up what this guy does on his own body, he puts a guide wire into his own, up through his own artery, puts it up into his chest, gets a nurse to go and take a photo of him, an x-ray. They get an x-ray to prove that he did this. And anyways, this whole story is that he got himself into so much trouble, but ended up beginning to be kind of the innovative physician that led to really what is going on around the nation, around the globe, every day, all day long, heart catheterization. So there's been this evolution of different physicians that have helped understand how do we get access to the heart without having to open up and do a bypass surgery, how the balloons work, how the stents work, all of those good things. So again, I have these videos in here for you to look at and read. Stents, again, if a stent doesn't work, we're usually going to begin getting symptoms while they're in rehab with us, while they're exercising. Those are going to be symptomatic patients, and we're going to have to evaluate, look at the EKGs, blood pressure, how much, nitroglycerin are they taking, and then oftentimes they may have to go in and get restented. Sometimes they'll have to go in and have a bypass done. The same thing can happen for the bypass patients, right? Someone who has CABG. They too can reocclude. We've got to watch those symptoms, and they may be having another bypass, or they may have a stent put into one of those bypasses. So lots of these possible complications can happen, but we encourage patients come to rehab to test your body. As much as you may not want to be exercising, I would rather you come to rehab and push your limits with us monitoring you on an EKG telemetry, kind of holding your hand and standing by your side, than going out and shoveling snow or mowing the lawn, and then realizing that, pushing yourself a little bit was too much. As I've continued to say, there are lots of new things happening, and these are just a few novel therapies. If we were to do a lit review in the a library database, we'd find a lot of really great information on what's going on with cardiac revascularization and technology. So here's a photo, a nice photo that we see. This is left anterior descending. We got a blockage there. The blockage is not letting blood go through there, so now we have this area that's hazy. It's kind of, ischemic. This area of the heart is not getting blood flow. So they can either go in and do a bypass, they can go in and do a stent, angioplasty and stent, right? This is what we call ischemic, right? This ischemic area is not getting adequate oxygenated blood flow, and they can die, right? Have a full MI and die, or end up having to have an intervention. These other photos are just different things that are kind of out and being talked about. This one over here is showing you how they can drill little holes into the heart with a way of trying to help with little laser, right? So little lasers directly into the heart that are trying to help the body uptake more blood flow. The other one is angiogenesis, and angiogenesis is injection of genes, right? So injected genes, and angiogenesis, you know what that means, right? New growth, to try to stimulate new collateral growth. And what I like to say on this one, so this is a photo of collaterals. Collaterals, you see some collaterals up here too. Collaterals are little branches that grow off of our coronaries. So we all have kind of the standard main coronary arteries, right? You have your main, your left anterior ascending, your right, your circumflex, etc. But with our coronaries, we have the ability to grow new branches, just like a tree, right? So trunk, and these branches and all these other ones. These are what we call collaterals. So this science is trying to stimulate collateral growth by using different types of angiogenesis stimulation. In our field of exercise physiology, our body has the ability to produce increased circulation on its own. So what we know about exercise is the more we exercise, the more protective mechanism our body has against heart disease. One thing that's been proven is someone who's a lifelong exerciser, kid, middle school, midlife, all the way, right? They're just a very active person. In an angiogram, right, in the cath lab, they will see that they have more collateral circulation. They have all these little branches. When you have more collaterals on your heart, it means your heart is getting a huge, great surge of blood. So here is science trying to stimulate collateral growth. I'm here to say what you're trying to encourage people to do is just go exercise, right? Because that in itself has the ability to do new collaterals. Okay, so basic outcomes when you think about treatment. So we have, I went over CABG and I went over stenting and angioplasty. The other thing I want to go over are who are these other types of reasons of who you're going to see in cardiac rehab. So you're going to have your classic bypass surgery, you're going to have your classic angioplasty, but you're also going to have people that have heart failure. So with heart failure is contractility has changed, right? So impaired ability, either the left or the right or both ventricles are not doing their job. They're either not filling or they're not contracting. So systolic failure or diastolic failure. This is an important slide because we're seeing more and more Americans suffering from heart failure. We are getting people to live longer lives. So you're living to an older age, but not necessarily healthier. So as we're getting better at keeping people alive, it comes at the cost that we're seeing more and more heart failure. The other thing about why we see more heart failure is we're getting people diagnosed early on with bad risk factors. Right? We're a pretty unhealthy nation. Sedentary, obesity. So we're having a lot more risk factors at an early age that's taking a toll on the heart later on. So what somebody feels like with heart failure is they're weak, fatigued, shortness of breath, very little ability, exercise intolerance, fluid retention. These might be people in your family that you see are kind of like swollen neck and fingers and ankles, right? Fluid overload, edema, right? That's a big sign of heart failure. What are the causes? Heart disease, heart attack, hypertension, smoking, obesity, high cholesterol, diabetes. So our nation is plagued with all of these risk factors. The many more years we have them, the more the heart gets weakened, and it really takes a toll on our energy, our blood flow, again, edema. So heart failure is a big thing we'll talk a lot about because it's one of those diagnoses that you're going to see in a rehab unit. I'm not going to ask you to know these different stages, but depending on the severity of heart failure, a patient will come to us staged, meaning how severe is their heart failure. The thing you need to know about heart failure and exercise, different than heart disease and exercise, or cardiovascular disease, or atherosclerosis. When it's just heart failure, we want them to exercise, but we don't usually see a giant difference in their outcomes, in their physiological outcomes. Right? We don't usually see their heart getting stronger, but we see their quality of life improving. But that is a big thing. The second diagnosis that we want to talk about is stroke. Right? So stroke is classified under CVD, cardiovascular disease, but with stroke and heart disease, which kind of goes together, oftentimes we see loss of brain function. So depending on the severity of the stroke, right? There's two types of there's a few different types of strokes, but ideally we've got a hemorrhagic stroke, which is a bleed, and we've got an obstruction, which is an occlusive, a thrombus, and embolism. Okay, so it's either hemorrhage or obstruction. So it's bleed or it's blockage. Symptoms can be hemiplegia, right? So partial paralysis, it can be coordination, vertigo, memory loss, speech, vision, behavioral problems, right? All of these different things neurologically can happen. Most of the strokes we see are what we call ischemic stroke, right? So they did not get the blood flow, right? Loss of that blood flow caused cell death, and that's when we end up getting the neurological outcomes. Something called a TIA. A TIA is a transient ischemic attack. We know these as mini strokes. TIAs are people who say, well, I think I had a stroke, but not really a stroke. They're dangerous. Usually somebody who has one TIA is usually going to have another one. We do call them a mini stroke. The good news is they didn't have any long-term symptoms or paralysis. The bad news is that usually they're at risk for more. So strokes, as are with classic heart disease, take a very big amount of behavioral interventions, strategies to modify their risk factors, to change, they lower their risk. Right? Everything this class is about, right? Modifying behavior to change cholesterol, hypertension, obesity, smoking, being sedentary, any of those things are really what we want to be looking at. The third one I want to talk about, it says on my slide PAD. I'm going to tell you the more correct way. It should be PVD, so peripheral arterial disease or peripheral vascular disease. This is peripheral, right? Your legs, commonly the legs, it can be other places, also can get blockages, right? We're talking about the CVD, cardiovascular disease, throughout the whole body. So with PVD, we end up getting blockages commonly in the legs. It can be femoral, popliteal, tibial, any of these arteries. The classic symptom is called IC, intermittent claudication. Strange word, right? So intermittent claudication is when people complain that their leg hurts, it burns, it's painful, it's a sharp pain. They describe it all very differently. Intermittent claudication is a sign of what we call peripheral vascular disease. So these are people who have blockages in the arteries in their extremities, and the blood flow is not getting to the working muscles. So the more they walk and the more they move, the more their legs burn and ache and really hurt. What you see is that then they sit and rest, and it's magically relieved. So these may be people you might know in your family, or you'll meet with them in a clinic, where they learn to do things and they sit and rest and then do it again. So intermittent claudication is a common thing we see in cardiac rehab. We're seeing a lot more referral to rehab with PVDs. So only about 10% of patients report having intermittent claudication, because it depends on the severity of the blockage. They usually don't get pain until the blockages are really progressed. There are physicians that they call themselves limb savers, because they're now sending patients to cardiac rehab, making them exercise, pushing that blood, right, making them get the blood really in their extremities, walking, riding a bike, all of these things that makes the person hurt. But these limb-saving doctors are saying, but if you exercise and really force that blood flow down into your limbs, we are going to save your limbs, because when PVD gets bad, oftentimes you can end up seeing amputations. You may not have known that. So you can see an amputation with PVD if we don't intervene quick enough. But now doctors are beginning to refer them to exercise, cardiac rehab, right, vascular centers, which is now covered by Medicaid. It wasn't before. Saving the limbs via exercise, because that blood flow is being pushed into those legs, and the legs begin to overcome that. So the biggest risk with peripheral artery disease, as it says, increased risk of heart disease, stroke, heart disease, gangrene, amputation. Right? This all stems from leg pain. We see a lot of leg pain really being from smokers. Right? So when you take a look at peripheral arterial disease, it's blockages in the limbs, and risk factors: heart disease, hypertension, diabetes, smoking, classic that we talk about all the time. Same risk factors. We just don't know if it's only going to be in the heart or it's going to be the arteries down the legs. So the word is claudication, and we use the word intermittent because it comes and goes, right? Ischemia increases, so the more they walk, their legs need blood flow. The muscles, the gastrocnemius, the quadriceps say, hey, send blood down here. The heart's sending blood down to those working muscles. There's a blockage in there, and all of a sudden, the muscles start hurting, right? Intermittent claudication, because the blood can get through those blocked arteries. They sit and rest, and it dissipates. When we talk about the word ischemia, right, the person's legs become ischemic because they're not getting blood flow. When they get ischemic, we start feeling pain. So it's called angina when it's in the heart. It's called intermittent claudication when it's in the legs. Again, we can stage peripheral arterial disease. I'm not going to ask you to stage it, but it can come ranked, as most all conditions can come ranked to us. Let's talk about the 3 non-modifiable risk factors. So age, right? Everyone's getting older. We can't stop that. We know the older you are, the more your risk factors are. Family history, right? So genetic makeup. And then the third that's not listed as much anymore is the difference between men and women, because we have a difference between estrogen and testosterone. What we want to focus this class on, and what the next couple of assignments you're going to do, is focusing on how do we modify risk factors? What are the risk factors? So smoking is a big thing. We will talk about smoking cessation, right? Lots of chemicals contribute to the damage and how fast atherosclerotic plaque process happens. As I mentioned in our first lecture, the last lecture, endothelial layer of that artery gets damaged, right? So the more we're exposed to stressors such as smoking, we can see a more aggressive form of heart disease happening. You know that. That's why you don't smoke, right? Positive risk factor is, this is what you want to know, is if someone can get to 6 months of being smoke-free for 6 months, then we know that their body's beginning to regenerate itself. The fact is, can we get a smoker to be smoke-free for 6 months? The goal is complete cessation. However, if we can't get to complete cessation, we'll at least take reduction in smoking. So I spend a lot of time talking about smoking. In the class, people will ask about vaping and secondhand smoke and marijuana and all of these other things you can inhale, smoke. Lots of research has gone on to the effects of the heart and lungs, and we know that any type of chemical agent we're putting in is going to change the way the heart and lungs are functioning. I have seen lots of middle-aged and older people say, well, I'm going to go from smoking to vaping, right? So, and that was kind of a big thing, like 10, 15 years ago when vaping first came out, was this transition that a vape is going to be healthier. It's not. But if it's, it's all very complicated, and I'm going to do a talk on smoking cessation to try to help us understand smoking cessation is a really hard thing, but it's one of the big risk factors we really need to be focusing on. Hypertension, right? So anyone with a systolic above 120 or a diastolic above 80 is hypertension. How do we help hypertension? Well, if they are above 120 or 80, they need to be on medicine. The other thing is lifestyle modification, which is weight reduction. So what we know with weight reduction and blood pressure is losing just a couple of pounds. Here it says it's in kilograms. So losing 10 kilograms, which is not much, a body weight, can be up 5 to 10 millimeters of mercury of blood pressure. So weight reduction. A DASH diet, which you all got through, I don't know, Nutrition 101, right? A DASH diet, rich in fruits and vegetables, low fat, really being aware of what kind of fat content you're bringing in, right? So if you're going to be eating protein, where are you getting your fats from? That's what we call a DASH diet. There are some cardiologists that put people on extreme diets. We'll talk about those two extreme that are healthy but very, very restrictive, that can be difficult to follow. At minimum, teaching people about different types of fats is good, right? So there's different quality of fats. Different meat products would have different fats in them. Vegetables, all of these things have different fats and proteins. So kind of understanding the basic nutrition, that can help blood pressure. Sodium, absolute sodium. Sodium is direct linked with blood pressure, direct link with obesity as well. So when you look at sodium levels, you're looking at how much ranch dressing you're eating, how much Taco Bell sauce you're putting on. Any pre-packaged condiments add to your sodium. Anything that came in a box has huge surge of sodium. So understanding how to read a label is part of cardiac rehab and patient education. Physical activity, most the population is not getting nearly enough minutes a week, some getting no minutes a week, right? Sit time is at an all-time high. So engaging in activity, teach them how to move, reminding them easy ways of moving, and then alcohol consumption is another link with blood pressure. So when you're looking at alcohol consumption, you're looking at how much they're drinking, how much body weight they have. But we have seen in studies a lowering of blood pressure numbers as someone reduces their intake of alcohol consumption. So that's blood pressure. The other one is cholesterol, right? So the big thing is LDL, which I mentioned a little bit when we think about intake, right? LDL cholesterol is what we call bad cholesterol. For heart patients, we want their goal to be 100 or lower. Triglycerides, right? We want those to be under control. These are two areas of blood draw that we want to be aware of in a cardiac rehab. So in cardiac rehab, everybody gets sent to go and get another cholesterol test done, because they're usually on medicine for their cholesterol. Then we start giving them an exercise program. We couple both together, and we should begin to see a big difference in LDL levels going down and triglyceride levels. So saturated fats is what we're looking at. So when you think about saturated fat, you're thinking about anything that had a face. So saturated fats come from things that at one point had a face, right? A fish, an egg, milk, the pig, the cow, the chicken, right? All of this has saturated fats. The level of saturated fat depends on, which one of those I just said. So being aware of someone's cholesterol levels is all of you should be aware of your cholesterol levels. You're probably in your 20s. Go and get your blood drawn. See where your LDLs are. We can't feel this, right? So if you innately have high LDLs and you're eating bacon 5 times a day because you're on the bacon diet, and your LDLs are already crazy elevated, I'm going to say that's the wrong diet. You may like bacon, but your body is not processing LDL to the point that you should be eating that much bacon. So we need to know our numbers in order to understand the diet and how extreme or how limiting we need to be. So without knowing your own numbers, you can't help yourself. In cardiac rehab, everyone will have blood drawn, so you'll have the baseline, and then within 4 to 6 weeks of exercising, we're going to send them for another one. So a lot of patient education on cholesterol, weight management, and physical activity, right? Can we get them to either maintain or lose weight? And can we get them more active? The most common medicine is going to be a statin medicine. It's almost kind of like standard therapy these days that a doctor is going to put somebody on a statin, which is a cholesterol medicine. Sedentary living is another big risk factor. That's why you're in this major, is to learn how to get people moving who don't like to move. So obviously, we're trying to get people to move at any amount of minutes. If you're going by regulation guidelines, you're trying to get them 5 days a week, 30 minutes, but sometimes that's way too much for someone who's just beginning. So being aware of sit time, timing how many minutes you're sitting in a chair, logging your steps with a pedometer or an app, really cutting down exercise into 10 or 15 minute intermittent chunks, finding ways of getting them to move. Resistance training. For some people, they would rather do resistance. That's great. Lure them in that way. They still have to be doing the aerobics, though, as well. Obesity is a big, big problem. No pun on that word there. So it's an independent risk factor, right, than everything else. It is linked to many things, right? Having obesity, hypertension, diabetes, heart disease, all of these things. The more fat we have, the more adipose cell we have in our body, the more we become glucose intolerant. You know, glucose intolerant is pretty much type 2 diabetes, right? So your body just doesn't know what it's doing anymore. There's too much fat on it. So lots of complications with significant complications with people that are too fat. Being too fat happens at a young age, usually. So we want to change the way kids are living and eating. So we're not dealing with a lifetime of being overweight, and now someone's in their 20s or 30s and they've been overweight their whole life, versus changing it at that kind of pediatric level. Anyways, our goal is to look at both their BMI and their waist circumference, right? Men need to be under 40 inches, women under 35 inches. That's our waist circumference. BMI less than 25 is, the goal. Impaired fasting glucose, like I just mentioned, with too much adipose fat. So chronic hyperglycemia is what accelerates heart disease. It accelerates peripheral vascular disease. It accelerates the risk of having a stroke, right? So when your body is not breaking down glucose, a surge of things are happening in the actual body. So it says promotes monocyte recruitment, adheres to the endothelial lining, ends up stimulating inflammation, and before you know it, the end goal is atherosclerosis. One of the big goals we have in cardiac rehab is this hemoglobin A1C. You see it advertised on TV commercials. This should be in the goals you have for a patient, is what is their hemoglobin level? And after X amount of weeks exercising, changing their diet, changing their exercising, we should see their hemoglobin A1C less than 7. What is that? Hemoglobin A1C is a fast blood draw that pretty much, in a nutshell, it's kind of like a crystal ball for a doctor. It kind of can tell them over time how much fluctuation they've had in their glucose level. The higher the hemoglobin A1C level, the worse their glucose numbers have been. They've been too high. Does that make sense? So it's one draw that kind of gives an estimate over time, is kind of an easy way of describing it. So with rehab, diet, exercise, behavioral interventions, we should be able to get their hemoglobin levels down and keep them down, because now they're living differently. They're living much more healthy. Common medicines that you see, I'm going to go over all of these in another lecture. We'll antiplatelet medications to decrease clots, anticoagulants, coagulation, common one, anti-anginal, anything to helps to minimize angina, so nitroglycerins and different types of patches they can be on. Hypertensives, blood pressure medicine can be a diuretic, right? You know that as a blood water pill, right? Diuretics. A beta blocker, we'll talk a lot about beta blockers and how those beta adrenergic receptors can change the demand on the heart. Calcium channel blockers do the same thing. Calcium channel blocker is going to allow for more vasodilation, so you're getting more blood flow. An ACE inhibitor, angiotensin converting enzyme, that's another one that's going to help decrease blood pressure, decrease vasoconstriction, and overall fabulous. ACE inhibitors are common medicine that's prescribed after a heart attack as well. Angiotensin receptor blockers is another great one that's going to help lower blood pressure. These are all, again, we're not prescribing the medicine. I want you to be able to look at medicine and understand what it's doing, and then obviously understand what some of the side effects are that the client could be complaining about. Hypercholesterolemia, right? Statins I mentioned before, very, very common. Statins are cholesterol medicine that usually takes a big dose of lowering the LDL. The problem with statins is the kind of side effects. All of our cholesterol medicines seem to have a good amount of side effects that, if you can keep your cholesterol low now in your 20s, you're probably going to be good later on in life. So what you're eating today, even if you're not overweight, what you're eating today is going to be the end product of your LDL by the time you're 40. So remember that independent of how much you weigh, what you put in your mouth is a product. So if we can keep your cholesterol good while you're young, the need for having some of these really potent chemicals of cholesterol-lowering medicine, they're great. They do their job. They're going to lower the cholesterol, lower the risk for heart disease. The problem is the side effects that people complain of, which we'll go into when we do our pharmacology lecture later. So anyways, that is my lecture. This week, your assignment this week is to read all about risk factors, right? So I'm going to read about risk factors, and I want you to be able to answer my questions that are uploaded up there on Brightspace and uploaded by next Sunday night. So if you have questions, you know where to find me via email, hunt me down. This is a long lecture, so hopefully you'll listen to it in small chunks.